But I just want to clarify that Kris is qualified to speak on multiple topics at this meeting. He could have talked on Hep C, which I did. He could have talked on NASH, which Steve Harrison did. He could have talked on HFE. He could have given a talk on end-stage liver disease, and hepatitis B. So Kris is actually a model hepatologist who has done research in multiple different areas and become an expert, a recognized expert in multiple different areas. So I want to give you that recognition, Kris, before you give this talk. Thanks.
Thanks, Paul. It's always great to be at this meeting, and the quality of the presentations and the attendees and the interest and engagement is really extraordinary. The reason he had me wait to give all those laudatory comments was because he wanted to do a preemptive strike, because what I was going to say with friends like Paul, you know, so I can speak on a variety of topics, but there's a couple that I don't speak on, and guess what Paul assigned me? I'm going to try and struggle with you to try to make some sense of the best of portal hypertension and cirrhosis from the liver meeting. So there's quite a lot of interest in hematopoietic cell therapy or stem cell therapy or GCSF. There was a study that came out of India that showed that in patients with severe acute alcoholic hepatitis, the difference in survival with GCSF was about twofold higher in the group that got GCSF. And so that generated a lot of interest. And in fact, a community GI doctor called me last week with a young man with acute alcoholic hepatitis and said, should I use GCSF? And I was very impressed. So hematopoietic cell therapy with GCSF, the concept, I think, is that it may improve liver regeneration. It's available, so you can prescribe it. It's unclear if single or multiple cycles of therapy should be used. The argument that these investigators made was that previous studies have been underpowered and dosing hasn't really been adequately studied. So they wanted to look at GCSF in patients with decompensated cirrhosis. It was a non-blinded study of 100 patients who were given either 4 cycles of 5 days of just sub-Q every 12 hours GCSF at 3-month intervals with standard medical therapy or just standard medical therapy alone. It was randomized but non-blinded. And so here's the primary outcome was transplant-free survival. There's a lot of wording on the slide, so let's just go through together. A secondary outcome, mobilization of CD34 positive cells, which is a measure of GCSF downstream signaling, improvement in Child-Pugh score, and improvement in MELD score. And then clinical events, control of ascites, episodes of infection, liver stiffness, nutrition, quality of life, need for liver transplant, and adverse events. So 74 versus 42% improved 12-month transplant-free survival. Pretty good. Significant increase in CD34 positive cells at day 6. Median change in MELD scores from baseline to 12 months, significantly better in Group A versus Group B. You can see there's about a 3-point reduction with a range from -9 to +5 versus 1, significant statistically. Child-Pugh scores improved significantly in the treated group, -2 versus 1, and significant improvement in control of ascites, reduced episodes of infection, hospitalization rates, better quality of life, reduced liver stiffness, etc. No improvement in nutritional status, and safe and well tolerated in decompensated cirrhosis. This has kind of changed how I think about it. I don't know if it'll be easy to get it in the hospital setting, but we have patients who are decompensated, maybe acute on chronic, maybe there's some precipitant that tipped them over the edge. They may not be transplant candidates. Maybe this is something to consider. Portal pulmonary hypertension, as you know, is part of the spectrum of pulmonary vascular disorders that occur in patients with cirrhosis. There's hepatopulmonary syndrome, which is largely substantial shunting in the lungs. And then there's portopulmonary hypertension, where in the setting of portal hypertension, you get pulmonary hypertension. So here's a study where, so here's a definition. So all patients for this reason, primarily in addition to other reasons, should have transthoracic Doppler echocardiography prior to transplant. You want to consider right heart catheterization, calculate pulmonary vascular resistance to look for portopulmonary hypertension. The definition is systolic pressure, pulmonary artery pressure greater than 30. Right heart cath is recommended in selected cases with confirmation and grading. And this is divided into mild, moderate, and severe, with definition based on mean pulmonary artery pressure, pulmonary artery resistance, and wedge pressure greater than 25, greater than 240, less than 15, or in severe, greater than 45, greater than 240, with less than 15 on medical therapy, respectively. So it's clearly an issue for a subset of patients with cirrhosis. We're very nervous about transplanting those patients. There are limited therapeutic options, and whatever drugs we have, which are largely these endothelin antagonists, have significant side effects, particularly with regard to hepatic morbidity and mortality. But the post-transplant morbidity and mortality is high. This drug, macitentan, was shown to be effective in long-term efficacy in pulmonary artery hypertension and had a good hepatic safety profile. And the management, was effective in pulmonary hypertension. So this study was a 12-week randomized double-blind trial called the Portico trial, evaluating the efficacy and safety in portopulmonary hypertension. Inclusion criteria, patients had to have portopulmonary hypertension but couldn't be too decompensated. So Child-Pugh C or MEL score greater than 19 was exclusionary. Now here are the data. You can see that the drug was effective. There's a 35% reduction in pulmonary vascular resistance with macitentan versus placebo. And this was considered to be, this was statistically significant, and more importantly, safety and tolerability was acceptable. So I think for that patient, particularly that does not have severely decompensated liver disease, this drug may be in our armamentarium as we're working them up for transplant. So a reduction of PVR by 35%, significant improvement in pulmonary artery pressure and cardiac index versus placebo, no effect on mean hepatic venous pressure gradient. Adverse events were not significant. There were 4 patients discontinued, all unrelated to liver disease, and only 1 patient had evidence of DILI with AST, ALT greater than 3 with a bilirubin greater than 2. So they concluded safety was consistent with previous studies, significant improvement in pulmonary vascular resistance, and I think we have to keep this drug as a possible consideration. Another common concern is we see these patients who are critically ill with cirrhosis who develop sepsis. Acute kidney injury is almost universal in these patients, and we are always debating when to start dialysis. So we used to call this hepatorenal syndrome. I think there's still some patients that meet the criteria, but increasingly, as those of us that have been involved in trials with hepatorenal syndrome have discovered, acute kidney injury is often a superimposed process on underlying various other stressors. So the role of dialysis in these patients remains unclear. And the timing of renal replacement therapy is also unclear. I think we all agree you want to give albumin, you want to resuscitate the patient. This audience doesn't need to be reminded about any of that. In this study, they randomized patients to either early group dialysis within 6 to 12 hours of presentation or a late group dialysis initiated once the patient met absolute criteria: refractory hyperkalemia, metabolic acidosis, fluid overload, uremia or anuria for more than 24 hours, and they compared clinical outcomes and adverse events. I'm sorry the slide is a bit busy, but I'll walk you through it. 33 patients, critically ill due to sepsis in the setting of cirrhosis. Most common precipitants, pneumonia and SBP. If you look at the baseline demographics, they were comparable. Lactate levels were high. MELD scores were in the low 30s. Mean time to dialysis in the early group was 7 hours and 24 hours in the late group. And patients in the early group at 24 hours had higher serum bicarbonate, lower potassium, CVP, and phosphate levels. Mortality at 28 days was not statistically significantly different, but in the early group, there were fewer deaths due to renal failure, 0 versus 36%, lower incidence of intradialysis hypotension, higher urea reduction ratio, improvement in lactate clearance, and improvement in reversal of shock, and a greater frequency of recovery of renal function, 57 versus 7% in the early group, which translated into a 28-day survival benefit with a hazard ratio of 0.31, which is pretty impressive. So the conclusion was dialysis within 12 hours can avert serious metabolic complications, decrease incidence of intradialysis hypotension, and death due to renal failure. And so I think we need to start thinking about this. Maybe we are giving colloid, we're giving factor, we're giving blood. Maybe we should consider dialysis, particularly, in my opinion, if the patient has elevated lactate levels, we might want to introduce that earlier just to clear lactate. Now, frailty is a hot topic in patients with chronic liver disease. It is now increasingly clear, as we all know that work in transplant centers, that frailty has to be assessed independent of MELD sodium. And the relationship between frailty and complications of portal hypertension, though, are somewhat unclear. In other words, does ascites and encephalopathy interact or independent of frailty in terms of outcomes? And I think this has a practical significance for all of us, not just who work in liver transplant centers, because getting these people in a positive nitrogen balance, getting these people into nutrition and getting them up and moving before we even refer them for transplant is critical. So this is a study of adults listed for liver transplant without cancer at 9 US liver transplant centers. They underwent outpatient testing using this liver frailty index and balance, chair stand, grip, etc. Frailty was defined as this LFI greater than 4.5. On the same day as frailty testing, ascites was ascertained by physical examination, hepatic encephalopathy was measured by number connection test, and then they did regression analysis to determine the association between frailty as well as ascites and hepatic encephalopathy. They did this thing which I don't totally understand, but it was called competing risks regression, with liver transplant as the competing risk, assessing the subhazard ratio of waitlist mortality, defined as death versus delisting for sickness. So over 1,000 patients were studied. The population was 40% women, 61% non-Hispanic white. Interestingly, the MELD sodium was 18. So I think it speaks to the fact that many of these patients are in this MELD purgatory, but maybe sicker than their MELD scores reflect. 37% had ascites, 41% had hepatic encephalopathy, and 25% were frail. The odds of being frail were higher in patients with ascites or encephalopathy, with odds ratios of 1.9 and 2.4 respectively. However, among those with ascites or encephalopathy, patients who were frail had significantly higher risk of waitlist mortality compared to those who were not frail. And there's a figure, but I'm not showing you that. In competing risks analysis, so this is the interesting part where you're looking at MELD sodium risk of not getting transplanted versus risk of associated with transplant. Hepatic encephalopathy with this hazard ratio adjusted of 1.8 and frailty were associated with waitlist mortality, but ascites was not. So what this tells me is that the patient that has hepatic encephalopathy and frailty together has a much higher risk of having a bad outcome than a frail patient who has ascites. And common sense would tell those of us who've been seeing patients for a long time that that seems right, but it's nice to see this validated. In multivariable models that adjusted for MELD sodium, age, Hispanic race, and albumin, including ascites, hepatic encephalopathy, and frailty, only frailty remained significantly associated with waitlist mortality. Neither ascites nor encephalopathy remained predictive. So, frailty, ascites, encephalopathy, frailty is actually the most critical driver when you include all three of those together. So here's the figure that I alluded to in the previous one. You can see patients died or delisted, no ascites, no encephalopathy, and across the board, patients who were frail did poorly. And interestingly, patients who had encephalopathy or ascites and were frail had a much worse outcome. So in conclusion, frailty is common in cirrhosis patients with ascites and encephalopathy, strongly associated with waitlist mortality regardless of the presence of ascites or encephalopathy. And they came up with this liver frailty index, which I'm going to try to incorporate in our practice, consisting of 3 simple tests you can measure in an ambulatory setting, can be used in clinical practice as a tool to identify those with ascites or encephalopathy most in need of intensive prehab or an accelerated path to transplant, such as living donor transplant to prevent waitlist mortality. And I wonder whether there's a strategy for exception points for these patients if they are on a trajectory to get worse and otherwise salvageable. So interesting. Yeah.
What's the abstract number of that presentation?
Oh, it's, let's see here. 217. Sorry. 218 is bariatric surgery in patients with cirrhosis. Patients with this term I don't like to use, morbid obesity, have high rates of NAFLD and NASH. Bariatric surgery, of course, as you know, is an established procedure, but the safety in patients with cirrhosis remains a concern, and we're engaging a lot more, particularly as we're starting to do sleeve gastrectomies, to see whether it maybe is safer, acceptably, rather, whether the safety concerns may be mitigated by the potential benefit in improvement in metabolic profile. We also know that there are hundreds of thousands of these procedures done annually. Therefore, the vast majority are being done in the community setting. In the community setting, the outcomes are unclear. So this was a remarkable database from Dallas. So it's a Dallas-Fort Worth Hospital Council collaborative data warehouse. 95% of the hospitals serving this metroplex with 84 hospitals, 5.5 annual visits, and they have a unique ID that tracks any patient over time accessing any of these various systems. So it's really as much as you can get to a population-based data set. And then they looked at survival and risk factors. So here are the outcomes. So they have 4 categories of patients, right? They have a control population of compensated cirrhosis and decompensated cirrhosis. Then they have bariatric surgery and compensated cirrhosis, bariatric surgery and decompensated cirrhosis. If you just look at the sheer numbers, liver-related hospitalization for patients with bariatric surgery increased by tenfold in a 10-year period. 292 patients with bariatric surgery and cirrhosis were compared to 30,000 cirrhosis patients without bariatric surgery. And these patients were more likely to be women, have NASH cirrhosis, no different in the prevalence of alcoholic cirrhosis or decompensation. The 5-year survival for patients with bariatric surgery and cirrhosis is 57.9 versus 62.8%. Survival for bariatric surgery and compensated cirrhosis was the same as for a patient with cirrhosis and decompensated cirrhosis who did not have bariatric surgery. Bariatric surgery was not associated with improved survival in NASH versus alcoholic cirrhosis. And on multivariable analysis, bariatric surgery with about a 40% increased risk was associated with reduced survival even after adjusting for age, gender, NASH, and decompensation. So my take-home message on this is that a patient with bariatric surgery that undergoes, with compensated cirrhosis that undergoes bariatric surgery has a life expectancy that is similar to somebody with decompensated cirrhosis, and bariatric surgery in the setting of compensated cirrhosis related to NASH does not necessarily improve outcomes. So I think unless we're thinking about getting a patient ready for transplant, I'm not sure that bariatric surgery based on this data would be something we would endorse as a risk-benefit profile being favorable. Does that make sense? That's my take on this. So, all right, moving on, cardiac surgery in patients with cirrhosis. So this is the bane of our existence when we get called to the other hospital across the street, across town, where the cardiac patients are with elevated liver enzymes or jaundice or cholestasis. After the surgery, they call us. Frequent reason for consultation. Now, we know about risk of abdominal surgery in patients with cirrhosis. Previous studies have focused on risk stratification for patients who have undergone, quote-unquote, open heart surgery for valve repair or bypass grafting. But now we have all these transcatheter procedures, and the risk is not clear as to how that would be comparable. So there is the Society of Thoracic Surgeons score that assesses risk. Cirrhosis has been shown to negatively influence outcome after aortic valve replacement. So they wanted to look at TAVR versus SAVR for patients with cirrhosis. So they reviewed the records of 105 patients, aortic valve stenosis and cirrhosis, who underwent transcatheter valve replacement or surgical valve replacement. And they looked at long-term survival using Cox proportional hazards, and then they used a variety of obvious variables for adjustment. And then they had a control group. So the TAVR group had comparable in-hospital and 30-day mortality compared to the SAVR group. But the TAVR patients had a shorter length of hospital stay and less blood transfusion. During a 3.8-year follow-up period, there were 63 deaths. MELD score was an independent predictor of long-term mortality after adjusting for the usual things. In the subgroup of patients with MELD score less than 12, TAVR had increased mortality compared to SAVR, with a P that just reached statistical significance. So I don't think we can necessarily assume that TAVR is a more benign procedure from a liver standpoint. And here's the survival curve for TAVR compared to SAVR, and the dashed line is medical therapy after aortic stenosis in MELD less than 12 versus MELD greater than 12. So clearly you can see that for MELD less than 12, okay, surgery is preferred. MELD greater than 12, I think they all do poorly, so you have to question whether you can clear the patient for surgery. But what is interesting in this study, not a large number of patients, it's a retrospective review, but what is interesting is that surgical valve replacement appears to be associated with a better outcome in the MELD less than 12 group. Rising healthcare burden due to alcoholic liver disease in young patients. So this is abstract number 282. Younger patients have now seen a significant increase in terms of acute and chronic liver failure. The mean ages now are 31, more likely to be women, more likely to be obese, more likely to be Hispanic, hospitalized in the southern US and admitted with alcoholic hepatitis. 40% versus 16%. And in our hospital, this is a reality now. At any given time, we have a patient with severe acute alcoholic hepatitis who's a woman who is under 40, frequently under 35 years of age. Severity is greater in young adults, whereas older adults were more likely to have ACLF1, which is only one organ system failing. Young adults more likely to have variceal bleeding, hepatic encephalopathy, hepatorenal syndrome, and increased use of mechanical ventilation, renal replacement therapy, longer hospitalization, and higher hospital charges. So I think clearly nationally there's a move. It is at our center and in our region to really revisit our whole perspective about liver transplant in younger patients with severe liver disease, both ACLF and acute alcoholic hepatitis. Nosocomial infections in cirrhosis. This is, it's kind of a, tell me something new kind of abstract, but there's a couple of key points here. So this was the idea, what is can you predict nosocomial infections in patients with cirrhosis? That's the bottom line. And so nosocomial infections in this study, were more likely to be respiratory, UTI, C. diff, and fungal, with more VRE. Age, alcohol, admission MELD, admission lactulose use, interestingly, ACLF, AKI, ICU stay, or nosocomial infection were associated with 30-day mortality, and use of rifaximin was protective with a hazard ratio of 0.61. Nosocomial infections were prevalent in cirrhosis patients and associated with poor outcomes. They cannot be reliably predicted based on admission values, and all patients with cirrhosis who are at risk and should be monitored. So what my takeaway was, ACLF had a high odds ratio. Nosocomial infections immediately increase the risk of 30-day mortality, and rifaximin appears protective. Should we maybe add rifaximin to the order set to a patient that has, just like we do antibiotics for GI bleeding? I don't know, but I think it's something to consider. C. diff infections in patients with cirrhosis, discharge data from 4 state databases. Primary outcome was hospital readmission, multivariable regression, association of index C. diff infection with primary and secondary outcomes. So 1.5% of these admissions had C. diff in patients with cirrhosis. Significantly high mortality rate. So significantly more patients with cirrhosis with C. diff at index admissions died than those without C. diff infection, 17.9 versus 7.4. Of the patients who did not die or transplanted, those with C. diff had more readmissions. Significant higher rates of readmission with C. diff, with both 30 and 90 days, and inpatient death during readmission. And those who had the initial admission with C. diff had higher overall mortality, 24%. And C. diff is associated with a significant increase in overall mortality. Now, we all know this, but I think it's very useful to see particularly the recurrent C. diff, and particularly the fact that if a patient with cirrhosis is admitted with C. diff, you have to keep this in mind. This is a large data set. 18% of those patients died in that admission versus 7%. It's pretty extraordinary. And finally, Dr. Sundaram shared some slides with me from a presentation that he had. And this is about acute on chronic liver failure, and I want to thank him for that. So acute on chronic liver failure, as you know, is acute hepatic decompensation with extrahepatic organ failures. Liver transplant remains controversial, especially with 3 organ systems failing. So this was a retrospective analysis of the UNOS registry database. They use a standard criteria for identifying ACLF and use standard statistical methods. So of 100,000 waitlist patients, 80% had no acute on chronic liver failure, but 9% had 1, 6% had ACLF2, and 5% had ACLF3. Across all categories, these were predominantly men and more likely to be Caucasian. Most patients with no ACLF had Hep C, while most with ACLF3 had etiology due to alcoholic liver disease. And it's interesting to speculate that maybe that has to do with increased bacterial translocation and a leaky gut. But here's the cumulative incidence of 1-year waitlist mortality, significantly driven by number of features, number of ACLF factors. And the key point on this slide is that in patients without ACLF, mortality rate tracks with MELD sodium score. But in patients with ACLF 1, 2, and 3, even patients in the lowest group of MELD sodium scores may have very high mortality rates. So this again raises the question about whether we should be using some other factor as a qualifier to MELD sodium in prioritizing patients, because if somebody has a MELD sodium of 25 but has ACLF3, they have a 45% mortality, which is not reflected by their MELD sodium. Death or waitlist remover within 90 days, very similar. Again, there's sort of a trend with no ACLF, but with ACLF, particularly in patients with lower MELD scores who have higher ACLF status, the mortality rates are at 28 days and 90 days remain quite dramatic. And here's the post-transplant analysis. Of the 51,000 transplant recipients, 56% had no ACLF, but a substantial percentage, therefore, 28 plus 12, 40%, had some degree of ACLF. And again, 1-year post-transplant survival seemed to be associated with presence of ACLF and the severity of ACLF. What are the risk factors associated with 1-year mortality post-transplant? Interestingly, a DRI greater than 1.7 and mechanical ventilation were associated with significantly higher, well above 1 confidence interval for patients who had ACLF. So there are also some factors that we might be cognizant of with regard to maybe prolonged mechanical ventilation or other donor factors. So in conclusion, with this study, waitlist mortality among ACLF3 significantly high. MELD scoring system does not capture the prognosis for these patients, and I would guess that maybe we should have a new modification to MELD sodium to try and add ACLF to an adjustment to give these patients higher priority. Presence of mechanical ventilation is associated with greater post-transplant mortality. And so just like historically, if a patient has pneumonia or invasive fungal infection, we're very reluctant to transplant those patients. We might want to consider something like that for a prolonged mechanical ventilation. Liver transplant does improve care, and more research is needed. All right, thank you very much.